Good afternoon, welcome to In the Trenches. I'm David Cohen, and today we're going to talk about anticoagulation. And we're going to start by going over the coagulation cascade. We have the extrinsic pathway and the intrinsic pathway. Start with factor 12, go into factor 12A, factor 11, go into factor 11A, factor 9, go into factor 9A, factor 10, go into factor 10A, prothrombin, go into thrombin, and that's converting fibrinogen to fibrin, and then factor 13, converting fibrin to stable fibrin, and to convert nitrogenide A cofactor here is factor 8A, and here we have factor 5A, adding factor 10. This is the intrinsic pathway. The extrinsic pathway, we have tissue factor, which is going to convert factor 7, factor 7A, which is going to come in here and work here. So, although it's not legible, this is a sketch outline. Let's go over the names of these factors, and also it should be noted that calcium and phospholipids are also involved in the coagulation cascade of different pathways. So, factor 1 is fibrinogen. Okay. Factor 2 is prothrombin. Factor 3 is, we'll get back to that in a second. Factor 4 is calcium. Factor 3 is tissue factor, rather. Factor 4 is calcium. Factor 5 is proacceleratin. Factor 6 is actually, there's really not a factor 6. Some call it activated tissue factor. Factor 7 is proconvertin. Factor 8 is anti-hemophilia factor. So factor 6 would be activated factor 4. Factor 8 is anti-hemophilia factor. Factor 9 is Christmas factor. Factor 10 is Stewart factor. Factor 11 is PTA, or plasma thromboplastin antiseton. Factor 12 is Hagman factor. And factor 13 is fibrin stabilizing factor. All right, all these factors are made in the liver except factor 8. Tissue factor, and factor E is made in the capillary endothelium and megakaryocytes. Okay, and the vitamin K dependent factors are 2, 7, 9, and 10, and I'll get back to this in a little while. So basically, with anticoagulation, you're trying to interrupt these factors. And your options here that I want to describe, and this is just going to be a basics talk. You have heparin, you have low molecular weight heparins, you have direct thrombin inhibitors, and you have fondaparinux, and factor 10A inhibitors. You have factor 10 inhibitors. The oral ones, which would be rivaroxaban, apixaban, and doxaban. We'll talk about them in a couple of minutes. Basically, heparin is going to antagonize thrombin. This is activated factor 2, and this is the big gun. And you give IV unfractionated heparin, it will work right away. And basically, it has multiple modes of action, but it activates antithrombin 3, which it's also called antithrombin, and that antagonizes thrombin. Now, two other important parts of the coagulation cascade are protein C and protein S. And these are also vitamin K dependent. And protein C inhibits factor 8 and factor 5. So whether you bleed or clot, it's a fine balance. And if you have too much of these, you might bleed too much. And if you don't have enough, you might have a little more factor 5 and factor 8 and be prone to clots. Okay, that's what protein C does. And protein S is kind of a cofactor for protein C. So antithrombin, protein C, and protein S are basically, they offset the coagulation cascade. Now, heparin work on other factors also, and it also inhibit some platelet aggregation, make the capillaries less prone to clotting, and also has some endogenous anti-inflammatory activity. And this is a medicine that we used really all the time as an initial drug to treat clots, blood clots in the legs or lungs, or vascular clots like in the coronary arteries and acute coronary syndromes, until the low molecular weight heparins came out. Okay, and the three that are around, the enoxaparin is the predominant one used in the United States, also dalteparin and tinzaparin. And what these do, okay, they inhibit factor 10, much greater than they inhibit prothrombin. So that's 2. So you talk about 10A, 2A activity. They inhibit 10A a lot more than 2A. For this reason, you don't have to put patients on IV drip, and you don't have to monitor blood work. Monitoring PTTs with heparin could be difficult. So they came out in 1996, and the idea was now a lot of patients wouldn't need to be admitted with DVTs, maybe PEs, and you could do some of this at home. It gets trickier than this, though. Then around the millennium, fondaparinux came out, and it was really a parenteral 10A inhibitor. And there's good data, it just never got used that much. And then we started with the oral drug. So the direct thrombin inhibitor orally is dabigatran, which is Pradaxa. That first came out for AFib, and it was the first NOAC approved for AFib. And then you had the 10A inhibitors, okay, which are rivaroxaban, apixaban, and edoxaban. And these drugs work directly on 10A. And you can give them orally, and they can work right away. And there's a lot of data for these drugs for treating DVT and pulmonary embolism, and really shifted the treatment for the outpatient setting. A lot of these patients who would previously have to be hospitalized. I want to say a little bit about warfarin. Warfarin is not used nearly as much now. It's still used, it's just not used nearly as much. A very difficult drug to use because difficult drug to use because it's very hard to dose. Now, basically, it inhibits the enzyme vitamin K reductase, which inhibits which inhibits the carboxylation of the gamma carbon. And the precursor molecules. And by doing that, it makes the factors not effective. They're there, they just don't work as well. And different people have different levels of vitamin K epoxide reductase. And the other thing with warfarin is really a racemic. There's an R form and an S form, a racemic mixture. And the R form is less potent, the S form is more potent. And there are certain drugs that are metabolized by the CYP2C9 system that will increase the metabolism of the R form, decrease the metabolism of the S form, and increase the INR. So when you're using warfarin, in most cases, when you're treating DVT or PE, and that's the area that I want to focus more on, you could need at least a 5-day overlap with heparin, and really depends how long different people take different amount of times to reach therapeutic anticoagulation. Using edoxaban and dabigatran do something called switch therapy, where they get low molecular weight heparin for 5 days, and then you just switch them to this. And it's just the way the trials were set up. The other drugs like rivaroxaban and apixaban, you could use right away. You don't need a switch period. Heparin is not used as much, but if you have somebody who's unstable and you want them on a medication, you can titrate. That's your medication. Also, your creatinine clearance. If your creatinine clearance is less than 30, you're not going to be using these medications. Not in this venue. For AFib you might be, but you're not going to be using it for VTE, and you're also not going to use low molecular weight heparin. So this is kind of a quick overview on anticoagulation. This field has really changed over the past 20 years. First from heparin and Coumadin's also warfarin, add to low molecular weight heparin and warfarin to the NOACs, or DOACs. Warfarin, interesting, that's rat poison. And warfarin actually stands for Wisconsin Alumni Research Foundation for Rat Eradication. What happens, they used to give it to rats and they would bleed to death. And somebody came up with the idea, maybe this could work as a blood thinner. Difficult to use, not used as much. But the DOACs are certainly used a lot, as is low molecular weight heparin, and unfractionated heparin is still used in hospitalized patients. And with that, I'm going to stop.